hopefully this case will also elucidate some points around pelvic ring fixation as we talk about CurvaFix in this particular patient. So our patient's a 70-year-old female with a history of metastatic pancreatic cancer that was recently diagnosed. She's on chemotherapeutic agents, along with participating in a clinical trial for a drug therapy. She's also already received radiation therapy. She has a history of chronic cervical spine and low back pain that's been long-standing and has been treated conservatively by spine surgeons. She has had no history of acute trauma to her pelvis or acetabular region. She presents to the ortho spine team with acute new onset, what she was calling low back pain. They, of course, obtained an MRI, which revealed bilateral fragility fractures, with the left being more prevalent on the MRI than the right. And you can see it on these imaging studies here. Prior to her acute new onset low back pain, she was using a cane to ambulate, and now she was forced to use a walker as a result of the significant increase in her pain, particularly with ambulation. There was no concern on her imaging, both from the radiologist as well as on our review and from her oncologist, that these were metastatic fractures, but rather more likely bilateral insufficiency fractures secondary to some of the chemotherapeutic agents that she had received, along with the radiation therapy. She was then referred to our orthopedic trauma clinic, where we continued conservative care for her, given that this was a relatively new onset diagnosis. We continued her on the walker. We added vitamin D to her regimen. And in discussion with her oncologist, we altered her chemotherapy by stopping her methotrexate. We did not think it wise to stop the remainder of her chemotherapeutic agents, and she had already completed a course of radiation, and she wasn't due for another course for some period of time. She returned after 2 months with increasing pain, focal to her low back, particularly over her sacrum, and further increased dependence on her walker. She was clear to discern that this was distinct and different from her pre-existing chronic low back pain. And having had prior exacerbations of low back pain, this was quite different to her. And she noted that as her disease process was fatal, she wanted to ice skate with her kids again, she wanted to ice skate again and also walk with her grandkids. This was really important to her as she could see the sort of the end of her life coming forward. So in discussion with her at length and her family, along with working with our oncologists, we chose to go down the road of sort of a palliative care treatment for her in terms of giving her some pain relief and trying to stabilize her posterior pelvic ring such that she could be a little bit more functional as she tried to manage through her pancreatic cancer. In looking at her CT scan, we discussed posterior pelvic ring fixation for her bilateral insufficiency fractures, which had failed conservative treatment. We were looking at potentially doing bilateral upper sacral segment screws, as well as a transiliac transsacral S2 screw. I did not feel that I would be able to get a single screw in the upper sacral segment from the left to the right side, given the anatomy of her upper sacral segment. It was my opinion that I could probably at best do bilateral S1 screws and then a transiliac transsacral S2 screw. However, with the opportunity to use the CurvaFix device and in discussion with her, we elected to proceed with a single upper sacral segment screw along with a single S2 screw that would be transiliac transsacral. And so we took her to the operating room. This is the starting point for the upper sacral segment screw that would be transiliac transsacral. Again, one of the advantages or opportunities with the CurvaFix device is that it allows you to not be quite as precise with your starting point because of the ability to, as you can see in this image, get your guide wire around the sacral tunnel. So this is the S1 tunnel you can see here, and you can see that I'm able to pass my bent guide wire around the S1 tunnel on the near side. You can see the lateral view there with the wire posterior to the iliocortical density and anterior to the S1 tunnel. I can then pass my wire further laterally across midline over the opposite side S1 tunnel, approaching the SI joint on the far side, and then using an exchange tube to then pass my wire that I would ream over. Here you'll see an image of the upper sacral segment screw in position, and then an image of us passing and starting to pass our S2 screw. The one thing that I did learn from this case was that due to the size of the screw, particularly on the outlet image, the size of the screw limits the visualization of the S2 component. So the S1 screw blocked my ability to see my S2 wire. So my S1 screw was so wide that the S2 wire was blocked on my inlet view. So I would say that one thing that I learned from this was that if you are going to be placing an upper sacral segment screw and an S2 screw, to pass the wires first and then pass your screws. We did this as an outpatient procedure. She was neurologically intact post-operatively. We discharged her home. Weight bearing is tolerated with her walker with really no restrictions. And her VTE prophylaxis as well as her pain medications were per her oncologist. We did obtain a post-op CT prior to her discharge home from the PACU. And you can see a safe passage of the upper sacral segment screw on the left, as well as the S2 screw below. She returned to clinic 3 weeks status post her percutaneous transiliac transsacral fixation of her bilateral sacral insufficiency fractures. And you can see from her history that was obtained by not myself, but my PA, that she was doing well. She was happy with surgery. She had no pain in her pelvis status post the surgery. She was able to ambulate with the walker with improved posture. And she noted, quote, such an improvement in quality of life. The only issue that was limiting her at this point, and again, only 3 weeks after her surgery, was her known chronic back pain that she attributed it to. Thank you.